Dr. Churchyard is going to talk us about preventing MDR treatment. So Dr. Churchyard is the group CEO for the Arm Institute and a specialist physician in HIV and TB. He's also a researcher who focuses on preventing drug-susceptible and drug-resistant TB in people living with HIV and household contacts. Welcome.
Thanks very much, Vanessa, and thank you very much to the organizers for inviting me to give this presentation on treating drug-resistant TB infection. I'll start by giving a brief background and then describe some regimens for MDR TB preventive therapy and the trials that are ongoing of MDR TPT, and then discuss some of the feasibility and accessing households of MDR TB patients and give some strategies for how to deal with that, and then conclude. So in terms of background, there's a large burden of MDR TB globally, and it's associated generally with poor treatment success, and many people die from MDR TB. Household contacts of MDR TB patients who become infected have a very high risk of progressing to TB and death. In 2014, the World Health Organization issued guidelines which included recommendations for multi-drug resistant TB infection, and they recommended that strict clinical observation and close monitoring of TB disease be conducted for at least 2 years. But in 2014, they only made a remark that clinicians, as part of good clinical practice, could consider individually tailored preventive treatment. Following that, the Harvard Global Health Delivery Dubai conducted a systematic review and meta-analysis of published studies, which included many observational studies, and based on that, they made a recommendation that at least 6 months of treatment should be given to MDR TB contacts, which included a fluoroquinolone, either levofloxacin or moxifloxacin, with or without ethambutol or ethionamide, and to follow up household contacts for 18 months post-exposure and investigate for TB if indicated, and to build programmatic capacity for delivering MDR TB preventive therapy. In 2018, the WHO guidelines were updated based on the systematic review and meta-analysis, and the guidelines now recommended that MDR TB preventive therapy be offered to high-risk household contacts with documented TB infection, and the TPT regimen should be based on the drug susceptibility pattern of the index case and should include a fluoroquinolone unless the index case was resistant to levo or moxifloxacin, and that they should be monitored closely for up to 2 years. But these guidelines also called for randomized controlled trials to provide the evidence to update these MDR TB guidelines. So what treatments do we now have available for treating multi-drug resistant infection? So Eric Neurenberger has developed a mouse model of latent TB infection, and using this model, he evaluated individual drugs and combination regimens for treating the latent TB infection. And what this model suggests is that levofloxacin and pretomanid have similar efficacy to isoniazid, and that bedaquiline has similar efficacy in this model to that of rifampicin. So I'm going to go through these drugs now individually in a bit more detail. So starting with delaminid, and the reason why I'm talking about delaminid rather than pretomanid is that Otsuka has made delaminid available for evaluation for TPT. So delaminid and pretomanid are both nitromidazoles. They have potent intracellular activity against intracellular and dormant TB and appear to be safe and well tolerated and have minimal drug-drug interactions and can be dosed as a single daily dose. And there's now a pediatric formulation which is comprised of either a 5 or 25 milligram dispersible tablet. Levofloxacin, which is a fluoroquinolone, is licensed by the US FDA and has been widely used for the treatment of MDR-TB in both children and adults. It has known PK characteristics and does not interact with antiretroviral therapy, is palatable, and for levofloxacin there is also a dispersible tablet and appears to have low toxicity at currently recommended doses. Bedaquiline is a diaryl quinoline, and it inhibits ATP synthase and is also active against replicating and non-replicating TB. And what's important about bedaquiline is that it has a terminal half-life of 6 months. So Eric Nuremberg and his team again evaluated bedaquiline in a mouse model, and this mouse model predicted the efficacy of 6 months of isoniazid, 3 months of high-dose isoniazid and rifapentine, the 3-HP regimen, and the 1-HP regimen. And this mouse model predicts that 1 month of oral bedaquiline may have similar efficacy to the 1-HP regimen in the setting of drug-susceptible TB. And therefore, it seems possible that we could develop an ultra-short course regimen for MDR-TB infection of just 1 month using bedaquiline. Sue has already presented this data on the long-acting injectable, but this is potentially a game changer for treating MDR-TB infection, that we could potentially give just 1 or possibly 2 or 3 injections, which will hugely help with the adherence issues that we face with TPT. Isoniazid, an old drug, but we know has efficacy against MDR-TB with INHA mutations at a dose of 10 to 15 milligrams per kilogram per day, and that for MDR-TB with CAT-G mutations, a higher dose of isoniazid, probably at 15 to 20 milligrams per kilogram per day, is required. And this study, or the extension of the A5312 study being done by the ACTG, is just about to open, which will provide this evidence. Then there was an observational study done in Peru amongst household contacts of TB patients, a very large study involving over 14,000 people. But in this study, they looked at 201 patients or household contacts of MDR-TB patients who were less than 19 years of age, who received isoniazid preventive therapy, compared to 401 household contacts of MDR-TB patients who did not receive IPT. And IPT appears to have reduced the risk of TB by more than 70%. So this is purely observational. It is very small numbers, and this is pre-publication, so it has not yet been peer-reviewed, but nevertheless raises an interesting possibility that isoniazid too may have a role to play in treating MDR-TB infection. So moving on to the trials that are evaluating these different drugs, there are 3 cluster randomized trials that are designed as a superiority trials. The first one being TB Champ, that's been conducted in South Africa amongst children less than 5 years of age using levofloxacin. This study is now close to enrollment. The second study is the VQuint study being conducted in Vietnam. They too are also using levofloxacin compared to placebo for 6 months. They will be offering the levofloxacin to all household contacts regardless of age, but with a TST, a positive TB infection status. However, initially they were not approved to enroll children, so they have not been receiving the intervention. They are nearing completion of enrollment, and follow-up is ongoing. The Phoenix trial you've already heard about will be evaluating delaminid versus isoniazid as an active control for 6 months. This will be targeted to household contacts that are high risk of developing TB, that is children less than 5 years of age, those with HIV infection or immunosuppressed for other reasons, or with a positive test of TB infection. This will be done in 27 sites in 14 countries in the ACTG and Impact networks. In preparation for the main Phoenix trial, we conducted a study to evaluate the feasibility of identifying and recruiting index cases and their household contacts, and to describe the prevalence of latent TB infection, TB prevalence, and HIV infection amongst these household contacts. The average age of the individuals enrolled in this feasibility study was 25, and almost 60% were female. We enrolled participants from 16 sites in 8 countries, and the age distribution was what we had expected, but to note that 10% of household contacts were less than the age of 5. Almost 80% of household contacts did not know their HIV status. Almost all were offered HIV testing, and about 70% were tested, which identified another 5% of individuals who had newly diagnosed HIV infection. With respect to prevalent TB disease, the prevalence was high at 12% overall, but only 2% had bacteriologically confirmed TB, and this was largely due to a high proportion of children less than 15, particularly those less than 5, who had a high prevalence of possible TB disease rather than confirmed TB. The prevalence of TB infection was 72% overall, and increased with age, and above the age of 15 was above 70%, and differed by country as well. So overall, almost 80% of household contacts had an indication for being at risk for progressing to TB disease, requiring TB preventive therapy. Amongst these, almost 80% agreed to take or were willing to participate in a trial of TB preventive therapy for MDR TB infection, although the willingness did differ by site. So in conclusion, there's a large global burden of MDR TB. Household contacts of MDR TB index cases are at high risk of TB, and post-exposure management of MDR TB contacts is required, and the ongoing randomized controlled trials will provide evidence to inform policy for treatment of MDR TB infection. Thank you.